I am honored to be joined today by Dr. Martha Twaddle. And Dr. Twaddle has more than 30 years of combined experience in the care of seriously ill patients and their families. The Waud Family Medical Director of Palliative Medicine and Supportive Care at Northwestern Medicine. You are a clinical professor of medicine at the Feinberg School of Medicine, the co-chair for the National Consensus Project for Quality Palliative Care, which creates the palliative care clinical practice guidelines for the field, literally help to define the field.
Yes.
Winner of the 2019 Lifetime Achievement Award for the American Academy of Hospice and Palliative Medicine. And I am really pleased to say you and I and the rest of the team will be working closely to launch the Serious Illness Performance Collaborative, which is going to help palliative care organizations use data to succeed and through these new value-based contracts that are coming out. Dr. Twaddle, thank you so much for taking time to talk to me.
It's my joy.
So, so much that we should get to, but I want to take advantage of the fact that, you know, now when we think about palliative care, I think there's more of a shared understanding as to what it is. The name is starting to have more of a shared meaning amongst different folks in medicine, but it wasn't always that way. And you are one of the people that has helped to give it an identity, really. So I want to start all the way back with, was there a particular experience that helped you realize palliative care was where you wanted to spend so much of your time and career?
That's a great question. It's a series of experiences, really. And what brings me joy? You know, I think true vocation, I'm not the first to say this, true vocation is when your greatest joy aligns with the world's need and you find that expression of what is innately important to you. So I was a practicing primary care internist, and I also was initially, when I call myself chief residue, when I was chief resident at Northwestern, I volunteered at a local community hospice as a medical director. They're a brand new program. This is 1989. So hospice was pretty young. Jokingly, I think 10 years later, one of my patients was still alive. So we were really learning our way as to what hospice was and getting more professional about it. So those early experiences as a hospice medical director, and then also in primary care practice, what I discovered was where I really found joy is in caring for people who really needed me as a physician and needed me as a part of a team. I love the team concept, the interdisciplinary team concept is just the ultimate, I think, of the way to provide good care. I truly think that no physician should ever practice solo. They should always have a nurse and nurse practitioner with them, and ideally a social worker, because that's how we take better care of people.
Yeah.
And so early on for me, it was the realization that where I felt like I was truly in flow was in the care of the seriously ill. And formative in that time was the realization that we waited much too long to talk about quality of life. You know, so here we wait till like people are dying to have these conversations about, tell me what's most important to you in the last 3 minutes of your life, for Pete's sake. So could we move it upstream was really the question that I held in my heart, and that's how I discovered Balfour Mount, Dr. Balfour Mount at McGill, because he asked that question, and he found a way as a urologic oncology surgeon to integrate this whole person care model of hospice at the time of diagnosis.
Yep.
And start that journey years from end of life. And so I started incorporating it as an internist for my seriously ill people at the time of diagnosis, because I was often involved in the diagnosis. And then in 2001, when I really was there, just too many demands on a young mother, young physician, trying to juggle it all, I went full time into palliative medicine.
So now we can say into palliative medicine as though
Mm.
it's always been a thing. Um, but
Yeah,
I also know that it wasn't always that way.
it wasn't then either.
Yeah. So can you give us a little bit of the history? Because so I would tell you today that I'm in the field of data science. If you had
Mm.
asked me just a few years ago, I would say that it was computer science.
Mm.
Seen then. People have said machine learning, artificial intelligence, and I think sometimes fields struggle with their identity as they sort
They
of
do.
grow out of other fields and become
Yes,
their own thing. And
yes.
you had a front row seat, dare I say, at times the steering wheel. And so walk us through palliative care's struggles, evolution with
Yeah.
becoming what it is today.
Yeah, well, it's interesting that you touch on that because if you think about it, like the field of pulmonary medicine was tuberculosis, right? And infectious disease was syphilology. So we
Yeah, that's
do. You're absolutely right. We grow as the field expands. So this concept of moving this care model upstream to those who are seriously ill was what really galvanized me. And the story of Balfour Mount and his journey. So he trained as a urologist and did fellowship in oncology surgery at Memorial Sloan Kettering. And then he went across the pond, as he used to say, go see Sicily. And he worked with Saunders, and he incorporated this beautiful model of interdisciplinary whole person care of hospice and brought it back to McGill and wanted to apply it at the time of diagnosis because he was an oncology surgeon. And he knew he couldn't use the term hospice for all sorts of reasons. In French-speaking Quebec, it's not a word that resonates. Plus, he wasn't doing hospice care. So he's the one that coined the term palliative care. The idea of addressing the symptoms, of protecting people from the ravages of illness. So we were enthralled with this concept. It was highly relevant to us at Northwestern in 1990 because of the AIDS epidemic. So we had a devoted floor that we christened the palliative care floor that was 99% AIDS. And we had Dr. John Fair, who from infectious disease, and Dr. Jamie Von Rowan, who's still very active with ASCO in palliative care. She was one of our pioneers, and Dr. Charles Von Gunton. The joke was you had to be, I was Dr. Martha Von Twaddle, and Dr. Mike Von these names. But we were using the model of hospice, but applying it to people with serious illness. And at that point, AIDS was very much a terminal illness. And
Yeah.
the whole person demands the challenges that these folks faced with their illness and the stigma attached, as you probably well remember, in that time period were enormous. So it really required psychology and spiritual care, and as well as really excellent medicine. Well, then along came protease inhibitors. And the world changed. And by then, too, our work in palliative care was expanding, and we were taking care of people with heart failure and people with pulmonary disease, and particularly oncology. So since the inception of palliative medicine at Northwestern in the 1990s, that long ago, palliative medicine has been deeply embedded into oncology. And early on, and I love this, I'd love to go back to this model, we were called palliative and rehabilitative medicine.
Maybe my own curiosity. I can't let go of, like, I really want to understand 13 years to become a board specialty. But then how many years did it take you to complete the first official guideline as to what exactly palliative, really the definition of what palliative care was?
That's
13
so
to,
great.
13
Yeah.
to board certified, and then how long to have the first draft of the National Consensus Project?
So that began when I was president of the Academy, maybe even right before I was president. That was really pushed into being because there are many people who were saying they were doing palliative care, but they were just having advanced care planning conversations. They weren't operating as a team, and we had to define what are the essential elements that must be present for one to say that they are practicing palliative care. And inherent in that definition is the interdisciplinary team, right?
So I, I have read what you came out with, and you're all on version 4 now. But it took you how many years to come up with version 1?
So version 1, the process was the product. Important to reflect on. So
Yeah.
it took us 4.5 years. Now the funny thing too for me is every Friday afternoon we had a phone call for 4.5 years. I have never been that consistent with anything in my life. It's amazing to me, right? Wow.
Yep.
It was amazing. But also what Diane Meyer said during that time, I just hearken to so often, is the process is the product. The coming together of the nurses organization and NHPCO and the American Academy of Hospice and Palliative Medicine. And we also had CAPSI was very much there. And we had a consumer group at the time called Last Acts, which no longer exists. It was part of the early RWJ projects and end of life care. So we got together and we thrashed through and created this first set of guidelines. It was huge. We had over 1,200 references that were aggregated. That means so a review of our literature, which was pretty much anemic, but still, we pulled it all together, right?
Right.
And those guidelines came out, and Betty Farrell was part of that, and Betty Farrell was part of this last iteration as well. And I was part, of course, of the first one, and then Betty and I co-chaired this last creation. Now, the last creation took 18 months. It cast a wider net to the voices engaged in the process. It was rigorous and amazing. And what I love about this guideline set is it emphasizes a couple things even more. Of course, it honors and reinforces the absolute critical nature of an interdisciplinary team model. But it also talks about the caregiver. So it is well and good, and one must assess completely the patient and the patient's needs. But one has to also assess and risk stratify, so to speak, that caregiver or caregivers. We need to know who is involved in the care beyond the patient and find out what's their capability, what's their understanding, what support do they need. Because being a caregiver is an extremely stressful role. I've been a caregiver, and I deeply appreciate what it requires of us to be in that role. And I'm so excited that the guidelines come out and assert that one must assess caregiver capacity and stress. And what happens then when you create guidelines is they inform research, of course, they inform education, curriculum, but they also inform policy. And we are seeing Medicare Advantage programs that are now supporting private duty caregivers to come in and help, because really I credit these guidelines saying this is a must. You better pay for it because it's good care.
So it's so interesting when you say the process is the product. These guidelines are really codification of values.
Yes. Oh, that's lovely. Yeah.
Were there, and I know many of the names you mentioned, and certainly the organizations, the fact that it took a while to get that right, I wonder, were there competing opinions on what is in and what is out? And are there some that you know, in hindsight, you say, that really should have been in from the start? Or looking forward, you say, we need to sort of drop this. It's not what we thought it was. How has your thinking evolved?
There were definitely competing opinions of how things should be phrased or emphasized. And hospice was really the roots of a lot of what we have done in this country. It came out of hospice. And hospice did not want to be left behind. And so there were a lot of sparring, and there were jokes. I'd sometimes say, should I wear a black and white shirt and carry a whistle for this phone call? Because we've got in this corner, we have, people were passionate about their perspective. What's really exciting is we didn't leave anything out. We created these domains which have endured and have remained the framework on which we continue to build out, strengthen, and add. So in this set of guidelines, we talk a lot more about cultural appreciation. We talk about different ethnicities and also gender identities. And those weren't part of the conversation in 2003, but
Sure.
they are very, very important to the care of seriously ill people. Spiritual care, psychological care, all these aspects are strengthened, but nothing new actually showed up. We did a really good job in our framework.
That's great.
Yeah, it's amazing.
So, I think there's two themes, and you've touched upon them already, but they really jump out when you read your research in the areas that you speak about and teach about. And that is upstream. You get this expression over and over again, and also the importance of teams.
Yeah.
So I want to ask, I want to start with teams. I think a thing that I experienced when dealing with a family member's palliative situation, that is in contrast with the way I know you view it, is this idea that there is curative care, right? I, as your oncologist or surgeon, own your care. And then there is sometimes, in some places, palliative care, which might be considered a handoff, or, well, I'm not sure if you're ready for that yet. And so I would imagine you may have come across this once or twice.
Yes, fortunately, I don't live it.
No. And I think, look, you're in a privileged position that you created. So you've certainly earned it, but you're in one of the institutions that's been doing this forever.
Yes.
But not everyone that practices palliative care or that receives palliative care has the same benefit.
Yes.
So how do you think about, how do you train others, either specialists or palliative care specialists? How do you coach them to bridge this divide and to get past that barrier to what is really just good care?
Yeah, yeah. So from a program development standpoint, so through my career, I've had the privilege, the fun even, of creating different programs, services, some that still exist, some that don't. But when you create a program, you look for who's going to be a good partner. You don't go after the people who aren't interested in working with you. And the thing to keep in mind is most physicians are not early adopters. They are skeptics. They're like, show me how this helps me. Show me how this doesn't add more work for me. And many of them, most of them, show me how this really helps my patients. At the end of the day, this has got to translate into better outcomes, better care, success as I define it. So I look at palliative care as not another swim lane. Like I said, it's an integration. It's the connector. It's like the fibrous, amazing thing that holds cells together. It creates the communication, the web of caring around a person and family. And you help create better outcomes. So number one, you look for partners who are willing to work with you, and you work alongside them to find out what's important to them in the care of their patients, and you work for those common outcomes. So in oncology, we want people to do well with their oncology treatments. And one of the things, the early integration of palliative care means that people more often than not have better outcomes. They go through their treatment, they succeed, we celebrate together. We've seen some amazing things, particularly in this world of targeted therapy. And so our motto at Northwestern is live well and land softly. So we're also there not just for the person and the family that we're caring for, but we're there for our colleagues as they face the loss of a patient and they rumble with a sense of, did I do everything I should have done? Was it, we're a safe harbor for them to unpack regrets or worries, remorse, and grief in the care of their patient. And that's as a colleague and friend. So I think we play a lot of important roles, and as you align and become inherently important to the care delivery of a system. I was on with a patient, we did a joint telehealth the other day, and the oncologist was not with me, but on the screen with me. And he says to the patient, look, if we get palliative care involved, you're going to live longer and you're going to do better. It's like, I was like, trying not to go, wow.
That's,
they believe that because they've seen it.
yeah.
They've seen that.
Let's talk upstream.
Mm-hmm.
It was funny. First, it was really interesting to hear that HIV/AIDS might have been a really important driver of palliative care.
Huge.
And I didn't know that. Thank you for the education. But it seems to have then focused on oncology for some time.
Mm-hmm.
I read one of the pieces you wrote in 2003 was talking about West Nile as this next thing that may drive us upstream. And now we're living in the age of coronavirus.
Mm-hmm.
And again, upstream now could be as soon as you're in the hospital, because we don't know how fast this could progress.
Yeah.
So I think we all understand the concept of better palliative care is sooner palliative care.
Mm-hmm.
How do we avoid having to have this conversation again, like we did after West Nile and after HIV/AIDS? How do we make sure that after COVID, we don't have to continue to educate the public and the clinical practice community about how important it is to get palliative care upstream sooner?
Yeah. I think sadly, COVID, because of the nature of a pandemic and a god-awful infectious disease, where we're often involved, strengthens an older perspective on palliative care, which would be end of life. So where palliative care is integrated in the COVID pandemic is oftentimes, if we have an opportunity to talk to people before they deteriorate around advanced care planning, that's great. But many times we're on the other side. They've been intubated, they're not doing well. We're 16 days on a ventilator, and we are negotiating or gently walking that relationship and tender conversations with a family on the phone. It's a really it's a very, very challenging time across the board for the people who are experiencing this god-awful illness and their families, and for those who are provisioning the care. For me, upstream in palliative care is really the integration for anyone who has a serious illness at the time of diagnosis, so that they might have interdisciplinary team care nuanced to need. So one of the things very important in palliative care that's different from, again, a hospice model. Hospice model, everybody gets a social worker, chaplain, volunteer, they get a package deal. Palliative care is more a la carte. So you get what we're going to nuance this to what you need at the time. Certainly we are going to engage with our team to help figure out what your care plan should be. But it's not so bundled that you're forced to speak to these folks or have the assessment, again, is driven by whether or not there's unmet needs. So if somebody doesn't need chaplaincy, if someone doesn't need, and that would be rare, a social worker to help them identify additional resources, et cetera, or counsel, we're not going to have that person seeing the patient. They're going to be talking to us. So I think of, for example, one of my patients who I cared for, a great teacher for me, she had stage 3 melanoma, and then it became stage 4. And in the 13 years that I cared for her, as her quarterback and palliative care doc, she went through 3 clinical trials and 17 procedures. And she would say to me, it's palliative care that pulls this all together for me, because her neuro-oncologist was in Pittsburgh, her clinical trial was at Moffitt, her Another consulting oncologist was in LA. So I was the person who was helping to coordinate this, plus deal with the immediacy of symptoms, and counsel and help her make decisions as things evolved. Exciting thing for her is she was part of what was called PD1, Program Death 1 clinical trial, which is now the drug targeted therapy that's used for melanoma, and she responded. And she lived an additional 6 years, 6 years with stage 4. It was amazing.
That's great.
And actually, the end of her life was not because of her cancer. It was because her bone marrow just became exhausted, and she went into a totally aplastic crisis. Her bone marrow just said, I'm done. And she had no red cells and no platelets and no white cells. And even transfusions weren't effective. So she entered hospice care and was in hospice for not very long because of the nature of her final illness. But to me, that's upstream, is the idea of, through that over a decade of care, we were arm in arm integrating, helping find the right docs, organizing, etc. That's what I really love, because I love relationships.
Yeah.
I love it that I get to know my patients for a longer period of time, not just at the end of life. And like I said, some of my folks do really, really well. We had one gal with melanoma recently, stage 4, melted away. Her scans are clear. I mean, that's a big party.
Yeah, it's great.
It's a wonderful thing. Yeah, at some point it's going to be back, but hey. And we know it's not so much the destination as the journey together, and who's on your team and who's on the trip with you. And this gal feels remarkably supported by not just her oncologist, but also her palliative care team.
Martha, that's it. That's the questions I had for you. So let me ask, is there something you'd like to talk about before we hang up?
I have very much toyed, and I probably still will write a letter to the editor at some point in my career about this thing with our name, because it does concern me that it limits access a couple different ways. One is that being a hospice medical director requires a certain amount of expertise and extra study in addition to palliative medicine fellowship. And what I see, one thing happen is that people come out of a palliative medicine fellowship and they get hired into hospice, and they really need to apprentice, because they're very good at being a hospice doc and applying their palliative medicine skills. But the whole world of being a medical director is a whole level of expertise that requires study and application, and even another exam, honestly, which I ended up taking just to get more initials after my name, of course.
Yeah, of course.
And likewise, the challenge too is that if people think you're about hospice when you're integrated into upstream oncology or heart failure or whatever, that creates confusion. And we spend time trying to explain, no, I actually don't do hospice.
Right.
I'm doing palliative medicine. So I think we would serve our field better if we went to the name like everyone else in the US. And actually, when Bal founded the idea of palliative care, palliative medicine, he took the idea to Saunders, and she liked it, and that's what they call it in the UK. It's palliative medicine.
Yeah.
So they're readers of palliative medicine, not hospice. Hospice is a form of palliative. It's a place that we practice, not a specific separate discipline. So I wish we would just go to the pure palliative medicine name for our specialty.
It's really an honor to get to better understand a field from somebody who had such a role in shaping it and making it what it is. That's just special. So
Thanks.
I appreciate that. I'm really looking forward to working with you on the collaborative too, because so much of what I hope is next for palliative care is using data to demonstrate the value and to get the right care to the right people, to argue for reimbursement for this very valuable service. So, that's for us, that's the goal. If we can use data to drive value-based care, to drive better care, this is all worth doing.
Yeah.
And that's going to be fun. I'm going to start emailing you and calling you soon. We have a draft of the proposed curriculum for helping palliative care folks better understand our
Wonderful.
world. And this is you helping me better understand your world so I can do a good
Yeah,
job. When
so
all
we
get
can
together.
learn, so, because what is so important is that you speak the language of those who need what you're helping them with. And
Oh, yeah.
that's, 30 years. I'm still learning that every day, but I think I've gotten better at it.
Yeah, language matters. It really
Yeah,
does.
yeah.
All
Really
right.
fun. All right. Be
Thanks,
well.
Martha.